because it financially, you just can't keep on. I mean, I already get referrals from other pharmacies that just, don't want to deal with it, don't want to deal with the poor reimbursement and the extra time and effort it takes. And that's the chain pharmacies, send them my way. So does anybody else have comments on this or care to make a motion?
I just want to say, this is Philip. I want to say that I support that. I think this is part of addressing the opioid epidemic. We are not positioning the pharmacy profession for success, to make that happen. If we're part of the solution, then we need to really structure the payment as such. Because I mean, some of these places, I mean, where are patients going to go if they can't? We can't make this work from a transactional level. But I agree with Matt. You don't want to sound like you're being selfish, but physicians aren't coming and complaining about the same thing right now. It's just understood. So, but for Suboxone in particular, I think this is a key issue, and I'm supportive as well.
Okay, thanks for
this is Meredith. I support it for the Suboxone issue as well. And there's a lot of limitations to prescribing that the physicians are held to. We're held to dispensing. So that's a pretty clear-cut reason why there's no other choice, and we need to be reimbursed for that extra work and time and effort that goes into that, just as they are.
And a question out that I think Matt brought a really good point up is that, these places are dispensing, antidepressants in short term. They're dispensing, obviously, the Suboxone products, but they're also dispensing stimulants to prevent, such as Adderall, to prevent sleepiness during the day in case, to help out with their job. If anybody is practicing and has a Suboxone clinic near you, you realize there is a lot of high functioning individuals that this has given them their life back. Plenty, I've got dentists, attorney, teachers, different professionals out there that are able to carry on a normal life due to this therapy that they're getting. So I think it's important that, maybe we look at the drugs, but also possibly the practitioners that are practicing in these specific locations. But I realize that, we may have some family practitioners that are also doing this too. But so I'm asking, what's the motion that we want to make to hopefully have a solution that, Medicaid and MedImpact can agree with and work with us on it. And Fatima, if you're on here, if you want to make comments on that, anytime you want to speak up and make comments, go for it.
And I was just coming off of mute to address a few things. So, first, I think the concern that you brought up, I've heard this concern multiple times, and I want to, just say that we hear the concern and that we are working on an analysis. But the main distinction to make here is the difference between a dispensing fee and the ingredient cost. If we are discussing the dispensing fee, with Senate Bill 50, the dispensing fee rose significantly from the $2 to $3 that the MCOs were providing to now the 1064 that's in place. So with that being said, even if a prescription is being dispensed 4 times a month, let's say for a 7-day prescription each time, with $2 to $3 being the previous dispensing fee from the MCOs, the pharmacy should be evening out, if not making somewhat of a profit from the 1064 dispensing fee. So, that's one piece of it. The other piece is the ingredient cost. We understand that the ingredient cost of the drug has decreased, since 7/1. And we are looking into that. We are conducting an analysis to see what's going on from that perspective. So in addition, the claims pay at the lowest of logic, which I'm sure you all are well aware of, and price points like MAC and NADAC have opportunities to appeal the price. So if a drug is paying at MAC, we welcome any MAC appeals to go over to Magellan, and they'll take a look at the claim. They'll take a look at what the pricing is behind it and provide a response to that appeal. Similarly with NADAC, NADAC appeals are supported as well, and I'm happy to share that information with you all. So that's one piece of it. Another piece is that Suboxone dispensing overall should be easier with the implementation of Senate Bill 51, where we took off prior authorizations from MAT products overall. So I think from that perspective, the overall dispensation of an MAT product should not have as many barriers as it did in the past. So with all of those pieces combined, we can assure you that we are working on a comprehensive analysis of the ingredient cost of these products. And MedImpact is helping us with that analysis. So just wanted to let you all know so you're aware of that from the Medicaid perspective.
Oh, I can assure you in my 31 years of owning a pharmacy and pharmacies that I'm keenly aware of the opinion of Medicaid. So obviously what we just got through attesting to, you think is fairly reimbursed at a whopping $10.64 spread out over 4 times. So, thanks for putting us in our place and showing us that we're not really worth much, because that's exactly what in the fancy way you put everything is that's good enough. And the reason why we push for Senate Bill 50 is because we were losing on everything. And just because you go from $2 or $3 to now we're actually seeing a little bit of profit. Profit's not a bad word. It's not cussing anybody, anything. In order for all these companies out there, multi-million-dollar companies and little old hodunk places like me, you got to have a profit. I employ 54 people in Western Kentucky, and they would really like to know that Medicaid would like to, still have us around taking care of people in rural communities that are not going to be reached by the big companies. But thanks for putting us in our place, because what we just got through testifying to you isn't made up. It's the majority of people out there that are trying to do the right thing and take care of people. If you want to set aside some clinical guidelines that we can go by and we get paid for that on top of the dispensing fee and the cost of dispensing, or the cost of the drug itself reimbursement, which is already below cost, then I'm all for it. But don't tell us that the pennies that we get reimbursed are good enough. So do I hear a motion that we would like for Medicaid to consider and get some more testimony from some more people?
Yes, this is Paul. Give a motion.
Ron, I have a question. If the dispensing fee is not going to change for Suboxone, then would it be possible to have it to where doctors can only see them once a month? So we're only having to dispense once a month.
Well,
I understand how it's okay for one, but not the other.
We got to look at solutions, because obviously, we're going to be talking about several topics today that affect our bottom dollar. and make Medicaid more money. And, so it spreads out. So we got to look at solutions to the problem, because obviously we've been told that that isn't going to change. So we need to, if somebody would, Paula's made a motion, but make a motion, tell us what the motion is and see if we have any amendments to it. And I'll make sure that it gets mentioned at the next MAC meeting, and that it's addressed. And Kathy Hanna sits on the Medicaid Advisory Council anyway, so.
I make a motion that we revisit the dispensing fee for Suboxone products around MAT.
I'm sorry, Ms. Dr. Strupp, you're cutting out, please.
I'm sorry, this is Paula Schraub. I make a motion that we revisit the dispensing fee for Suboxone products for MAT therapy.
To either exempt it or 23-day, or what are you talking about there?
To increase, I guess to reevaluate the 23-day dispensing.
Okay.
Yeah.
Okay. We have a motion by Paula.
Yes.
Okay, do I have a second?
So is that motion clear that we're basically saying that we want to recommend to Medicaid that we would like to increase the dispensing fee?
Yes.
Okay, I second that then.
Okay. Motion by Paula, second by Meredith. Any further discussion?
I just wonder if we should be a little more exact with the motion. I'm asking, I don't know. Should we say a specific time or just keep it broad, like reconsider?
Well, I think it'd be to give them till their next meeting, which is in January, the MAC meeting. So either by the end of January or February to respond to if anything's going to be done differently with Suboxone clinic prescriptions.
Well, I mean, like make it a 7-day time frame instead of 23, or just keep it broad like the motion is right now.
Well, I think that you could, in my opinion, it should be considered an exemption of either Suboxone clinic doctors or practitioners, or that whole group of drugs that is prescribed by them, to have an exemption of the 23-day. Because in my clinic, they have a hard time getting people to show up to the mandated addiction interview and addiction counseling. And that's mandated. They have to do that. So if they give them a 7-day prescription, it has to be done within the first 7 days of them being seen. So what they do is they dispense, or they prescribe a 3-day or 2-day dose to get them to come in for their addiction interview, and then they'll give them the rest of the 7 days. So again, you could have multiple different days supply. So that's the reason why I think just exempting certain drugs, or exempting Suboxone clinics from the day supply. So I don't know if somebody wants to, if Paula wants to amend her motion or set a certain day supply.
We can amend the motion to include the discussion that Ron just said, which is adding or exempting certain providers that prescribe MAT therapy or Suboxone products.
Okay. Do you agree with that, Meredith?
Yes,
For your second?
yes.
Okay. Okay, there's a First and a second. Any further discussion? All those in favor say aye.
Aye.
Any opposed? Okay,
Ron, this is Charlotte. I just want to clarify something that you said just a few minutes ago,
sure.
was that you wanted to hear back from us like by January or something. And according to the MAC bylaws, the recommendations you all made today will be presented at the January meeting, and then DMS has 45 days to respond from the MAC meeting. So from your
Okay.
recommendations, it'll be sometime late February, early March when you get the response back from DMS.
Okay, thanks for that clarification.
All
And
right.
then also, and that's me presenting it to them, or is it already automatically done?
Someone, a TAC member must present it. So since
Okay.
Kathy Hannah's not a member of the TAC, so it would have to be either you or
Okay,
some member of the TAC present it to the MAC.
okay, that's what I'll do then.
All right, thank you, sir.
Thank you, Charlie. Okay. And on the non-COVID vaccination administration fee, very similar discussion as what we just had. Yes, it's nice because of the Medicare mandate that on all the COVID vaccinations, we get the $40 reimbursement. But on everything else, it's $3.30, which I realize was the prior admin fee, but that doesn't mean it's acceptable. So I look for a lot of pharmacy practitioners out there to just keep pushing people back to their primary care nurse practitioners or physicians, which will cost more money because they're not willing to pay us. And by the way, does anybody have any idea what the latest percentage of pharmacists COVID vaccinations for the whole nation? Has anybody heard that statistic? 70%. Pharmacists have delivered 70% of the COVID vaccinations out there. We have improved vaccination percentages since we've been able to administer vaccinations. So we are worth something. So again, on Shingrix, pneumococcal, everything else that we do, obviously the reimbursement on product acquisition cost or cost is usually minimal, and then the 330. So anyway, I just wanted to again bring this to your all's attention. First of all, give everybody else time to speak on this.
This is Paula. I just want to speak on behalf of the providers that they rely on the pharmacies and pharmacists in their areas.
I'm sorry again, but you're just cutting out.
I'm sorry. Let me move closer. I just wanted to speak on behalf of the providers in that they rely on the pharmacist to give these vaccinations. They don't have the ability to do a buy and stock these medications. And so it's really important, and they rely on their pharmacist. And I think that if we don't do something to supplement and improve the admin fee, then some of these pharmacists may not continue to do this. And then I don't know what we're going to do, because the providers really rely on their pharmacists to provide these immunizations.
Yeah, and just for instance, buying Shingrix at its smallest quantity is $2,000 for 10 doses. And, prescribers anymore just aren't willing to carry that inventory. And plus we are more accessible, and we've proven that the administrative, or that we get the job done on administration. And what we don't have, just like we just discussed prior, is the ability to charge for a clinical or office visit on top of, so whenever a doctor does it, they're not just getting paid the $3.30 plus whatever over the cost, which is usually very minimal, they're getting paid for an office visit. So that's the biggest difference. So thanks for your comments, Paula.
I'd like to make a comment. I support that as well. I think I had not heard that statistic about the COVID vaccines, and I'm not at all surprised. We needed a group that had the skill set to do that and step up. And one thing that is very true about pharmacists is we are accessible. We are very accessible. And, it's very easy, much easier for a patient to walk into a pharmacy and say, I need a vaccine, than to make an appointment to get it. And, if vaccinations are important, if it's easier for patients to get their vaccines from the pharmacy because the pharmacy is offering more because it's the payment is the administration fee is appropriate, then you will likely get more opportunities to vaccinate the Medicaid population. But some of the examples you talked about with the shingles vaccine, we see that in the UK healthcare clinics. We used to supply more vaccines to the clinics themselves, but I'm not sure I can put my finger on it, but I think what providers are seeing more and more is that, wait, pharmacists can do this. Why have you guys been doing more of this? So within UK healthcare, the providers in the clinics are saying, we'd rather just send patients to the pharmacy to do this. We actually don't need to see a patient for this. So if that is the case and there's more movement towards pharmacy overseeing that, then addressing the administration fee is important. But to really distill it down, it comes to being accessible. And, this is a way, appropriate administration fee for non-COVID vaccines will keep access in the forefront for Medicaid patients. And that's really what it's about.
Ron, this is Rosemary. I just wanted to add from the KIPA membership, which are the 500 independent pharmacies across the state, that our members are saying that they may not be able to continue giving the flu vaccines, just exactly what you're saying. So I'm hearing this from all across the state. And so I do support this effort as well.
Well, thank you, everybody's comments. Because it is a major consideration, especially when we have become, like Philip just said, there's a lot of practitioners in my area that used to do a lot of vaccines, and they're like, hey, I don't have to carry $5,000 and $6,000 worth of inventory. The pharmacists are used to doing that, and I want to send them enough patients. I want to send them all the patients so their inventory will get used up, and it's a good service, and it's just part of the healthcare team how we do it now. And I can also tell you that everybody on here, Meredith, Matt, Rosemary, and myself, the ones I know that are out there, seeing patients every day, and Paula too, is in the, I guess, community setting, it's not so easy, once you sit down with somebody, because you've got to do some research on, either KYR or call their doctor's office on certain vaccinations to make sure there's not been a duplication. It's going to be even better 5 years from now when we can easily look back on KYR and see that 5-year history. It's been really enjoyable for me. I had a lady who was in the hospital for COVID, and she received some type of vaccine. She didn't know what when she was recovering, and it turned out to be a pneumococcal vaccine. So I was able to look on there and see which one it was, and she was ready to get another vaccine that the doctor recommended, but I had to check all that history. So it's not just so easy. Somebody comes in and says, hey, I want this, and Shingrix or whatever, and you just say, yeah, let me get it and do it. There is an interview and research part of this clinical service, and $3.30 is truly minuscule compared to the amount of time and liability that you're taking on to do this. So does anyone care to make a motion to, for me to present this to the next MAC meeting?
I motion to present increase in the admin fee for non-COVID vaccinations.
I
Okay.
second.
Okay, first by Philip, was that Rosemary?
Yes,
Okay,
second.
second by Rosemary. Any further discussion? Okay, all those in favor say aye.
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 Any opposed? Okay. And Charlie, I'll get you all of these afterwards, and I know you've probably written a lot of notes down already, but I'll get these to you, okay?
That's fine. Thanks, Ron.
Okay. The next topic, the brand name rebate issue. I'm still trying to find, all of the drugs that are on this. I know there's a list, but I've had my pharmacist sending me new and, other drugs that I didn't anticipate being on it. Obviously, the biggest question that the media has been asking me just locally is that, okay, if Wellbutrin brand name costs $4,000 and a generic prescription, which has been used for years and years, is reimbursed somewhere $25 or below, that must mean that, and I know this is proprietary information, but that must mean that rebate must be coming in at $3,990 for this to be worthy of the taxpayers being good stewards of taxpayer money. So I have no idea what deal has been made with Medicaid, but just for instance, if you're dispensing a $4,000 drug when you could do it for $25 and you're getting $1,000 or $2,000 rebate, that's still paying $2,000 more for a drug, roughly, that we could have been paying a whole lot less. So I don't know where we go with this other than, because this is all about, in my opinion, being responsible stewards of Medicaid dollars that come from taxpayers. And we can talk all day long about what this means to the business model of everyone, because our whole business model in the community pharmacy world is based off of your generic performance rate or your generic dispensing rate. So if your brand names go through the roof dollars wise, that's going to throw many people off on their percentages and therefore not get our rebates, which has been our standard for eons now, about the higher your GCR, GER, generic effective rate. I mean, there's a ton of acronyms out there, but basically it's how you perform on dispensing generics. It also has something to do with, even in our Part D plans, hey, are you sticking to the 95% formulary? So we've always been incentivized to dispense the cheapest cost-effective drug. And yes, we all know that there's one-offs every once in a while for every PBM that they prefer a brand name, and it's usually a brand name that recently went generic, but they'll hold on to it for a while because of special contractual rebate that they have, but it's not wholesale like 10 to 15 drugs like we have here. So I wanted to let other people comment on this. And then hopefully Fatima, we can have a discussion with her.
Again, this is Paula speaking from the providers. I've had a lot of questions and confusion from the providers regarding not knowing which branded medications, getting calls back from the pharmacy because maybe the pharmacy isn't aware that a branded product is preferred. and they're just confused. So we're trying to do a lot of education at the PCA level to keep them updated. But again, they're a little confused and frustrated with all the switches to the branded products.
Matt,
Yes.
I was just calling on you because I saw you was reaching for your,
Oh, I'm gonna kind of just think out loud, and I want to see if I'm understanding this correctly. So I'm just going to use rough numbers here, but Wellbutrin XL brand name, 30 of them are around $1,500. The NADAC for the generic is around 14.5 cents per tablet. And I'm just going to assume Medicaid gets a rebate that we'll say the brand name, they're getting a rebate at 1 penny a tablet. So they're getting the rest of the money back. If that's a 13.5 cent savings per tablet. But if a 340B clinic dispenses a brand name Wellbutrin, they get to use the rebate, not Medicaid. So Medicaid, from my understanding, so someone correct me if I'm wrong, won't get the rebate on Wellbutrin brand name. And that would, if that's the case, it's going to take around 10,300 tablets to make it up just for one 340B clinic claiming the rebate and Medicaid not. Again, I might be wrong. I'm just trying to figure this out because I'm sure there's there's a handful of people that go to 340B clinics that'll be getting this. If I'm a 340B clinic, I'm thrilled at this happening, but it just seems, from my understanding, that it's maybe not the best thing fiscally for Medicaid.
Philip, do you care to comment on how it's affecting 340B clinics?
I have to look at it. It depends. It depends every quarter because the 340B contract price will change every quarter. So I don't know. I haven't looked at this one yet, but sometimes the 340B agreement, so 340B price is determined on pricing from 2 quarters previously based on the average manufacturer price. I haven't heard anything on this from Dan. So I'd have to get back on it. I have to do some more research to find out, but I appreciate you asking.
Okay. Fatima, do you care to make comments on this particular, the brand name rebate situation?
You know, one of the things that we're doing ever since we started hearing concerns from the pharmacies is putting together some educational material for providers. So with that being said, MedImpact is hosting a provider forum, which is has been going on a monthly basis. So we encourage all providers to log in and attend that provider forum. And, you know, we're happy to send any deliverables, you know, to folks who are unable to attend that presentation. So that will be next Thursday, December 16th at 1:30 p.m. You know, pharmacy should be receiving a notice with the Zoom link and information on how to join that. So, you know, hopefully that helps put things into perspective for pharmacies about, you know, the cost savings and the benefit to Medicaid as a whole. You know, the other thing I want to mention is we're not allowed to share the exact amounts, but we will provide estimates based on a drug class level at this provider forum, you know, just to put into perspective the cost savings from a fiscal perspective.
I guess, but if, I mean, let's just say you got it for free, just for argument's sake. If a 340B clinic uses it, you have to pay the full 1,500 and you don't get the rebate at all, correct?
Oh, yeah, that's correct. You know, we do not permit the duplicate discount.
That's correct from 340B standpoint.
So, I mean, that's, I mean, I feel like it would just take a few 340B prescriptions on this $1,500 drug to really wipe out any savings pretty quickly. I mean, if NADAC is $4.35 for 30 of the generic 150, I feel like you'd have to really do a lot of non 340B to make up for one 340B clinic claiming the discount on it. Assuming it's free or around that much. I'm just using that as a, I'm assuming it's less than $4.35 since that's what the generic is on NADAC. So I just, are you taking into account how many of those might happen? Because that's a pretty big loss to take on one script for Medicaid if that happens, $1,500 when it could have just been $4.35.
So we take multiple factors into consideration when making these decisions. And, you know, these are not decisions that we make lightly. So, you know, I can assure you that these decisions are made with care and caution. So, you know, we do take all of that into consideration and make a sound decision based off of that. And, you know, we hope that the presentation next week will really help tie things together and put it all into perspective for you all. Yeah.
Ron,
Yeah.
I think, you know, and I know Dr. Ali and I have discussed this and we've discussed it with the Medicaid department, but I think we have to look at a balance of this. You know, we need to look at the effect of what this is doing to pharmacies across the state, to community pharmacies. You know, what is it doing to us when we lose our rebates and when we are then filling prescriptions under our cost? I think we have to look at a balance of patient access. You know, if we're going, I mean, we all worked like feverishly to get Senate Bill 50 passed. You know, we did make concessions to 340B. We had to compromise, you know, because we initially went for a carve out, but we made concessions with 340B. And now, you know, here we are sitting and we have almost in effect lost the whole, I believe, what we gained with passing, you know, Senate Bill 50, because we've lost on the cost of the drug. We've lost on our dispensing fees, as we've talked about the other issues here. You know, we've lost on just different things. So I think there needs to be a balance of, you know, I'm hearing it from across the state. You know, we have independents who are now really in trouble again when we thought Senate Bill 50 was going to really help us, you know, keep taking care of our patients. I think that's number one. I don't know how many of you know, but on Monday at one of our Jordan drug pharmacies, we weren't, through our wholesaler, we weren't able to get any of the Wellbutrin or the Effexor. It was totally out of stock. And we had patients that needed refills. And again, I did contact Dr. Ali, and thankfully she worked with us, worked with all of us, not just with our company, but we did get a 72-hour stay and an override. But what's going to happen when the override's over? So there are a lot of issues here that need to be balanced. You know, we need to balance what rebates we are supposedly getting versus what patient care we're going to have. Are we going to have independent pharmacies still left in the state? And our number one concern is patients, are our patients.
Right. And it's amazing to me that it's the community pharmacies that are totally transparent, and they know what we're paying for the drug. They know what we're getting paid for the drug. But yet we can't find out anything else beyond that ourselves, because I think it would be pretty amazing to see what the bottom line gain or loss is on paying more for brand names, even if it's a, you know, certain percentage, because of, what looks like a great rebate of $2,000 on a $3,000 prescription, you're still paying $1,000, which is considerable more than what a generic is. So to me, who's getting the carve out now? We're getting drugs carved out, and Medicaid's making their own carve out to where it's going to cost people money. And I can already assure you that wholesalers, I know you deal with the same one I do, Rosemary, but I think Matt deals with a different one, and Meredith does too. But our wholesalers considering not carrying these brand names, because guess what? That costs them money too. And there is a carrying cost for dollars on the shelf. So they're looking at the fact of, well, we just may not carry those, and you'll just have to get it elsewhere. You also have, on most of these drugs, you got pharmacies out there that are saying, nope, I mean, this has affected my bottom line, and no matter how you sweeten it, no matter what you say, it's still taking money out of my pocket, which I cannot afford anymore. It's over. So therapeutic interchange is going to happen. And you have people who are well adjusted on some of these antidepressants, and the pharmacy is going to say, I'm sorry, but let's go with another drug that's not on a preferred brand name, because I got to survive, and hopefully you will too. So I'm hearing the whole gamut of things. So Fatima, when you're all considering everything, I'm sure none of those things were considered, because it is going to happen. We've been doing therapeutic interchange for PBMs for years and years and years. And whenever you're affecting our bottom line, which should be, a major consideration, then there's motivation to do something different. And especially when you got multi-billion-dollar companies going, I don't know about carrying this extra dollars because of carrying cost. So does anybody else have anything else to say on this, or a motion, either one?
I appreciate the 72-hour bill, to take care of the patient, because ultimately that's what we're here for. But again, it's just more work. Again, I'm going to fill it twice and just get paid, one time to do that? I mean, I had a prescription the other day for Metro Cream. Can't get brand name Metro Cream. I don't even know when I've ever used that. I have to take time to call the doctor to get a PA for the generic. So it's, again, just more time and more effort on that dispensing fee.
And you hit upon something really good there, Meredith. Some of these are drugs that we've not dispensed the brand name on in decades. And that makes no earthly sense too. There's plenty of other drugs like Bistolic and different ones that have gone off patent recently, that you could probably do okay on. But this right here, this goes against logic. And especially there's no way, given the circumstances of Matt's example a while ago, you would have to be getting a rebate of over right at $1,490 on that prescription to make it a justification to spend, or to get that rebate and actually spend less than a generic on a cash outlay. And I doubt that they're paying that much of a rebate. So I would appeal to Medicaid to please look at this and look at it logically. And if you're looking at getting a rebate of $2,000 when it costs $1,000 still, and when you can dispense a generic for $25, it doesn't come out for the taxpayer. Comes out, it makes it look like a lot of dollars are coming in, but you're also spending more money on the base price that you are paying for. Anybody else have anything on this topic?
Ron, I was just going to ask Fatima if at this forum, I know there's, you discussed there's limits on what you're going to be able to share. Will you be able to share the percentage of 340B versus non-340B that the rebate would be applying to or not applying to? Will you be able to share that information?
We will not.
do you have that information, but you just can't share it, or?
So, that's a little tricky per se to bring that into the conversation. I will say though that, these factors were taken into consideration. And, we will provide the numbers from a drug class level in terms of savings. I can circle back with Med Impact and have that discussion again and see, what we can and can't share from that perspective. So I'm happy to take that back.
Yeah, and what the I guess laughable part of this whole conversation we're having here is that Senate Bill 50 was to increase the transparency in the whole drug supply chain for Medicaid. And Medicaid themselves are creating more barriers to open information. So this will be something that our legislators will like to hear and hopefully do something about. So let's move on to number 6, compound formulary. I had Dan Grants and AJ Day. Dan works for UK, talking about all the compounds that and I sent y'all a copy of these. But basically it looks like the majority of the compounding that they do is for pediatric dosage form changes. Just like Ursodiol, Clonidine, Lansoprazole, Pantoprazole, Omeprazole, Atenolol, Topiramate, Quetiapine, Carvedilol, Bethanacol, Captopril, and Clonazepam, making all of those into oral suspension. There are some standards in Dan gave me some other ones that he even kept statistics on, that the omeprazole, that 2 milligram per milliliter suspension, he's in 6 months, they've dispensed 387 of them, prescriptions. Looks like a lot of seizure medications that they've had to make for children, a lot of those. But then you got your varying degrees of magic mouthwash, your butt balms, different combinations, whether it's nystatin, hydrocortisone, zinc oxide, bacitracin, different varying degrees of those. Obviously, this is something that would be a better treatment for pediatrics, not only, but there's also some people that have, cannot swallow, that are adults that need, whether it's geriatric population or somebody who's had an injury, that they need all their medications in liquid form. So it sure would be nice to start having some dialogue with Med Impact and CMS on this to, take care of a big problem, because a lot of these medications, if they paid for them, for compounds, it's a lot cheaper than some of the alternatives that are being put out there. And certainly the hospitals would not be eating so much losses on a lot of these prescriptions, because it's better treatment for their pediatric patients. I'll submit to Charlie and what I'll, present to the MAC on the different compounds that are being used, to inform them of what's going on and what the potential there is. I wanted to give somebody else a chance to comment on that, the compounds.
This is Philip. I can comment on it, and I'm glad Dan provided this information. I think this is because UK has, we have KCH. This is a nice sampling. It's not just KCH. There's adults here too, but it's nice sampling. I mean, a lot of these people, they're getting maybe like a script when they're being discharged, or if they're going to the homes. You're going to find this in the communities everywhere. And, you know, we don't make this unless you absolutely need it. There's patients that just will not take certain formulations, and it's a matter of them either taking their therapy or not. You know, it's an investment for any pharmacy to get into the compounding space. There's more equipment. The Board of Pharmacy has implemented 795 requirements. So it's not as easy as it used to be. So there's more overhead involved. Not because it's something like that UK is, but it's not like, this isn't an area that I think we're actively trying to get. You're being pushed into it because patients need it. Providers are asking for it for their patients. You know, recently UK, it was probably about 2 years ago, we joined with PCCA just so that we could access some compounds when we were presenting, because a lot of these therapies, you have to mix different compounds and have certain recipes that have been, you know, shown to be effective. So we're doing it out of necessity. But this is something that I think is only going to, I think a lot of this is pediatrics, but I think that there is going to be more of this coming in the future. A lot of therapies that are studied in clinical trials are, they are standardized to certain dosage forms. So it only comes in 50 and 100 milligrams and 200 milligrams. But based on how that medication is metabolized, it could be high on the metabolizer. And so where does the pharmacogenomic profile fall in there? And so that is coming more into focus now. I can see there being therapies where you really do need an alternative dosage form than what the FDA has already approved that manufacturers make. So I see that happening on the horizon, you know, regardless. And I think addressing compounding early on will help, you know, prepare Medicaid better for that, just because it is eventually going to be here.
Yeah, you articulated that very good, Philip, because it is a commitment. You know, just in my 2 labs, you know, spending $5,000 for a barrier hood to protect the compounder, $5,000 for an ointment mill to get a product reduced in size to be able to cross the dermal barrier. Homogenizers are between $2,000 and $3,000 to make good sound suspensions that people can swallow. Fee blenders are between $2,400 and $3,000. So you can go on and on the different apparatuses that people can have that can help get the products in a manner that are going to be absorbed better or taken better. Does anybody have any further comments on this particular subject? Okay, moving on to number 7, the reimbursement for non-insulin syringes. Paula, I believe you're the one that brought this to my attention.
Yeah, I had a pharmacist reach out to me that said MedImpact or your managed care Medicaid only covers diabetic syringes, and that a lot of the independents do B12 injections, and then therefore there are no syringes covered for those medications. And he wanted to have DMS reevaluate the ability for coverage for other non-insulin syringes. Okay. Yeah, this to me is a no-brainer because it's people wonder why, you know, here they're prescribed an injectable that they have to give themselves once a month or once every 2 weeks or once a week or once every 3 months, and don't have the apparatus that they got to pay cash for to do it. So
is there further discussion on this, or Paula, would you like to make a motion that we present this to the MAC?
Yes, I'd like to make a notion that we ask DMS to evaluate and include non-insulin syringes on the preferred drug list.
Okay, motion by Paula,
Second.
second by Matt. Any further discussion? All those in favor say aye.
Aye.
Okay, any opposed? Okay, motion carries. Okay, that's everything on our agenda. Thank you all for your time and efforts put into this. I'll be sending you our motions and our responses to Charlie and give you all a copy of them. So thank you all and have a great day.
Thank you.
Appreciate it.
Thank you.
Thanks. Bye.